Shall I start, sir?
Yeah, you can start.
11-year-old 11-year male child Raghu from Madurai, whose informant's mother reliability is good, came with chief complaints of delayed developmental milestones noticed since birth, convulsions in the form of tonic portioning of both upper limbs and lower limbs with uprolling of eyeball and frothing, which lasted for 1 hour. Since the problem started birth, I would like to start my history from the antenatal period.
Okay. So you got two chief complaints. One is delayed milestones noted since birth, and the other one is convulsions in the form of tonic portioning, which lasted for 1 hour. Okay, so since the problems are from birth, you start the history from the antenatal period. Accepted. So what do you think of this convulsions? The convulsions lasting for 1 hour. Do you have any specific name for that? Anything? Can you describe what is that convulsion lasting for so much long, lasting for 1 hour?
Status epilepticus, sir.
Okay. So what is status epilepticus?
Any epilepsy for more than 15 minutes or multiple seizures without regaining conscious in between, or a baby brought to the hospital with ongoing seizures should be treated as status epilepticus, sir.
Okay. Very good. But now the time they have reduced, even 5 minutes, they say it's more than 5 minutes, they say it's status epilepticus. Okay, so that's good. Okay, so what is the common cause for convulsions in children?
Sir, in neonates, the most common cause is hypoxia.
I'm not asking. A child with convulsion, what is the common cause for convulsion? You are in a casualty. A child is brought with convulsion. What is the usual cause? Very common cause.
Febrile seizures.
Very good. So a child with febrile seizures with status epilepticus, what else will you think of? Febrile
fever,
status epilepticus. Can you think of anything?
Infections, any infections.
Very good. Okay. So infection, CNS infection. You should rule out acute CNS infection or meningitis. Okay. Good. Proceed.
Antenatal history. Married at the age of 23 years. Non-consanguineous marriage. First conception. Antenatal history uneven full. History of stillbirth at 7 months of gestation, which was a male baby delivered through normal vaginal route. Second conception, which is the present child. Spontaneous conception with inter-pregnancy interval of 1 year. Age of mother at conception is 25 years. Booked and immunized at Kariyapatti PHC. Pregnancy confirmed urine pregnancy test at 60 days of amenorrhea. Pre-pregnancy weight and height not known. No history of periconception intake of folic acid. So first trimester, no history of fever with rashes and post-auricular painful swelling. No history of intrauterine procedures. No history of folic acid intake. No history of irradiation. No history of bleeding per vaginum. No history of hyperemesis and no history of hypothyroidism. First trimester scan done at 10 weeks of gestation, confirming singleton normal pregnancy. Second trimester, iron and folic acid tablets started from second trimester and taken regularly. Quickening felt at 5th month of gestation and perceived fetal movements throughout pregnancy. Ultrasound done at 5th month and 5th month and said to be low fetal weight as per gestation age and adequate labor. No history of oligohydramnias and polyhydramnias. No history of drug intake other than iron and folic acid. No history of pregnancy-induced hypertension, preeclampsia, eclampsia, and gestational diabetes mellitus. No history of antepartum hemorrhage. Third trimester, no history of gestational diabetes mellitus, preeclampsia, and eclampsia, and APH. No history of lower abdominal pain, fever, foul-smelling discharge per vaginum. No history of UTI. So labor details. Mother had true labor pain with spontaneous rupture of membranes. No history of foul-smelling liquor and maternal fever during labor to rule out choriamnitis. Birth history. Baby born at 8 months of gestation. Liquor not meconium stain. Taken to Madurai GRH within 1 hour. Delivered by normal vaginal route within 3 hours of admission. So it's a preterm male baby. Normal vaginal delivery. Birth weight is around 1.5 kg. History of respiratory distress since birth. Weak cry at birth. Resuscitation details not known. Passage of urine within 6 hours of birth and passage of meconium within 24 hours of birth. NICU admission. Baby admitted in NICU in view of preterm and low birth weight. Baby had respiratory distress since birth and under oxygen support for 5 days. Surfactant therapy details not known. Tube teeth started on day 3 and continued till 10 days. Then expressed breast milk started and continued till 1 month. Poor suckling and not taken direct breastfeed. Then mother started to give cow's milk and continued for 6 months. History of neonatal seizures present. day of onset of seizures not known, and discharge at 30th day of life with anti-epileptics, and advised parents to continue. No history of bleeding manifestation in the child, no history of neonatal jaundice, and no history of umbilical catheterization. Postnatal history, no history of history of feeding difficulties, poor suckling. Parents continued giving anti-epileptics till 1 year and stopped on their own. Developmental history, gross motor, head control attained by 2 years, rolling over by 3 years, sitting with support by 5 years. The rest of the gross motor milestones not yet attained. So developmental age is equal to 5 months by 11 years, which is equal to 4%. Fine motor could not reach out and grasp the objects, which is expected at 4 months. Developmental age is 0.4 by 11 is equal to 3%. Social and adaptive, social smile by 6 months, recognizes mother by 2 years, which is expected at 3 months. Other milestones not yet attained. Developmental age 3 months by 11 years equal to less than 3%. Language, cooing at 6 months, unisyllable 5 to 6 years, bisyllable words 8 to 10 words with meaning attained at 6 to 7 years. So developmental age 1 year by 11 is equal to 9%. Vision, child is able to recognize mother and family members and shapes. Child smiles at mother. Child is able to fix and follow objects. Hearing, child is able to turn head towards sound stimuli. Bowel and bladder control not yet attained. No history of constipation. History of presenting illness. History of convulsions in the form of tonic posturing of both upper limbs and lower limbs lasted for 1 hour, associated with uprolling movement of eyeball and frothing and loss of consciousness. No history of involuntary passage of urine and stools during seizure, for which child was taken to our hospital, and convulsion settled with anticonvulsants. Higher functions, no history of altered behavior present, history of sleep disturbance present, and no history of early handedness. Cranial nerves history, able to follow objects and recognizing parents, no history of deviation of eyeball and drooping of eyelids, history of abnormal involuntary movement of eyeball, able to perceive sensation on face, able to chew food properly, no history of deviation of mouth and drooling of respond to sound stimulus. No history of nasal regurgitation or voice change, history of difficulty in swallowing, able to turn head side to side, able to protrude tongue out, no deviation of tongue. Motor system, history of stiffness of both upper limbs and lower limbs noted since 6 months, history of difficulty in holding the child on hip, history of difficulty in changing and wearing diapers, history of scissoring of lower limbs. No history of paucity of movements of upper limb and lower limb. Upper limb, history of not able to move arm above head, history of not able to eat with a spoon or mixing food. Trunk, history of difficulty in turning in bed, history of difficulty in getting up from supine position. Lower limb, history of difficulty in standing from sitting position, no history of involuntary movements. Cerebellum, no history of involuntary movements of eyeball, no history of head nodding, no history of ataxia, and no history of involuntary movements of hand. 8, not able to walk, bowel and bladder control not yet achieved, no history of constipation. Complications history, history of difficulty in swallowing present, more towards solid food than liquid food. History of not gaining weight properly, no history of blood source, no history of contractions, no history of increased frequency of micturition and burning micturition, no history of fever, no history of vomiting, headache, altered sensorium, no history of cough and breathlessness. Past history, history of physiotherapy started at 6 years of age, no history of chronic drug intake or frequent IM injections, no history of recurrent respiratory tract infections. Immunization history, the child is immunized till date, BCG scar present. Family history, no history of developmental delay, neurological illness, seizures in the family members, no history of stillbirth in the family. Socioeconomic status, upper lower class. Environmental history, nuclear family, 4 persons, semi-paka house, no separate toilet, municipal tap water for drinking, no proper sanitary facilities, and no proper waste management. Nutritional history, expected calories 1760 kilocalories, expected proteins 33 grams. Shall I go through this, sir?
No need. Just tell the calorie gap and the protein gap.
Calorie deficit 900 kilocalories and protein deficit 20 grams. Contact history, no history of contact with an open case of tuberculosis.
Okay, before summarizing, we'll stop here and we'll have some discussion here. Before summarizing, can you go to the previous slide from your antenatal?
So which system you are discussing about?
Central nervous system, sir.
Okay.
So you said there is a history of stillbirth. So, so means the child was delivered at 7 months. So even the previous conception, that was a preterm delivery.
Yes, sir.
So could you make out any cause for preterm delivery, or could you think of, could you guess what could have led to the preterm delivery at 7 months of age? Any common cause?
Chorioamnionitis, sir. Chorioamnionitis.
Chorioamnionitis, accepted. So why I am asking this question is, so if it is going to be a recurrent cause, chorioamnionitis cannot be recurrent.
See, the first conception is a stillbirth, right? So this
Yes,
child was born at 32 weeks. Okay.
Yeah.
So chorioamnionitis cannot be recurrent, right? Unless otherwise the mother has a very poor hygiene and a poor maternal care, it can't be a recurrent one. So recurrent preterm deliveries, what will you think of?
Because on the when for the first child is a preterm delivery, there's a every chance that the next child also can be a preterm delivery. Moreover, okay, so when the first time is preterm, I should expect preterm. If the cause is known to me, if something is known to me, then I'll expect the same. If that is going to be that can be the cause for this delivery also. So I may anticipate some preterm delivery and try to prevent it, or make some adjustment, make some arrangement for that delivery. Okay, so for that purpose, we should know what is the cause for preterm delivery and at the first conception, first delivery.
It may be due to cervical incompetence.
Okay, very good, very
some
good.
Some anatomical issues in the uterus or in the cervix. Okay,
cervix,
some bifid uterus or your cervical
uterine anomalies.
Uterine anomalies. Point number.
Competence accepted.
Next.
Previous history of preterm labor is also a risk factor for the next pregnancy to have a preterm.
Okay, very good. Then
No idea, sir.
Now, where are the other tools who will be helping you? Are they?
where is Jeffrey?
Jeffrey? No.
Sir, sir.
Yeah. Can you answer? Few more causes.
So it could be the other cause which you can say is could be anemia complicating pregnancy, because although you have said the interpregnancy interval is short. What is the recommended interpregnancy interval?
3 years, sir.
3 years. Okay, so 3 years is the recommended interpregnancy interval. That is the time required for the mother to replenish the stores and all. But when you say short interpregnancy interval,
6 to 8 months.
Very good. So if it is less than 6 months, you will call it a short interpregnancy interval. But here it's 1 year. So if it is going to be anemia, it could have been recurrent or a recurrent UTI. Okay, urinary tract infection. Okay, vaginitis. So those things can also lead on to preterm delivery in the subsequent subsequent pregnancies. So you should expect. So when there is a preterm delivery, you should be cautious with the next conception also, next pregnancy also. Okay. When you say stillbirth, what is stillbirth?
During the process of labor, the child death of the fetus during the process of labor.
Yeah. So the child was baby was alive in utero, and when the baby was delivered, it didn't have any signs of life. That is what you call a stillbirth. Okay. What is the minimum age you should call a stillbirth? The minimum weeks of gestation.
After how many weeks of gestation it is called stillbirth?
Oh, more than 20 weeks, sir.
No.
That's not Indian standards. You are telling American standards.
More than 28 weeks. Sir, it should need terms, sir.
22 weeks. 22 weeks. Huh?
22 weeks. Okay, sir.
22 weeks and more than 500 grams. You call it as stillbirth. Okay. So this is the previous one was a preterm stillbirth. Okay. So both are risk factors for the next pregnancy. Okay. So again, the interpregnancy interval is also very short. Okay.
Now, what is the importance of age? Age of mother at conception?
Teenage pregnancies are more prone to get maternal anemia, leading to low birth weight.
Why did you ask about weight and height in this case, pertaining to this case? You have a CNS case, right? Okay,
Yes, sir.
a child with developmental delay. So how does height and weight of the mother, that pre-pregnancy height and weight is important?
Up to rule out contracted pelvis, sir.
Yeah, height is for
We need to prolong the labor.
Weight.
Obesity also, cephalopelvic disproportion.
Lean mother will has more chances of producing a low birth weight, right?
Maternal malnutrition.
Maternal malnutrition. Mother is malnourished, so that every chance of the baby becoming a low birth weight baby or an SGA baby, right? Okay. Why did you ask about periconceptual intake of folic acid?
Because periconception intake of folic acid will prevent neural tube defects in the fetus, sir.
Why you say it is periconceptual? What is the significance? When you should start? How much you should give?
It should be started before 1 month of conception, sir.
Okay.
And it should be continued at least for first 12 weeks of pregnancy, sir. The recommended dose is 400 microgram of folic acid, but available tablet is around 500 micrograms.
Okay, good.
Next slide. Next slide. No. Now, why did you ask for fever with rashes here in first trimester?
Sir, to rule out rubella infection, sir, maternal rubella.
Any intrauterine infection,
short infections.
One of the causes of developmental delay in a child, right? Okay.
Yes, sir.
Okay. So first trimester scan done at 10 weeks. Okay. Second. Okay. Proceed. Second.
Next.
Second trimester. So why we ask about all these things is we try to bring out as many risk factors possible. Okay. So that is the idea of asking so many questions in the antenatal, natal, or postnatal period. Okay. So because any event here would have will cause insult to the developing brain, and that can lead on to the neurological deficit later. Okay. So quickening was felt at 5th month. That is okay. Ultrasound here you said ultrasound done at 5th month showed low fetal weight as per the gestational age. What do you call that? How do you call that condition?
It should be IUGR, sir. Intrauterine growth restriction. Intrauterine growth restriction.
Okay.
So
mostly asymmetric IUGR maybe.
Why do you say it's asymmetrical? How do you classify IUGR? What is IUGR?
It is a clinical definition. It's a clinical definition, sir. It is a baby with features of malnutrition like emaciated appearance, peeling of skin, and peeling of skin, sir. We classify into symmetrical and asymmetrical IUGR, sir. Symmetrical IUGR is mostly occurs in the first trimester, sir. So due to maternal causes like chronic placental insufficiency, uteroplacental insufficiency, sir.
Okay.
Resulting in all the baby all the parameters.
Symmetrical is not symmetrical is due to
mostly from the fetal side, not from the maternal side.
Sorry, sir. Due to congenital infections and chromosomal anomalies, sir.
Yes.
Whereas asymmetrical IUGR, the uteroplacental insufficiency resulting in brain sparing effect of the fetus. So the head circumference remains normal. Rest of the parameters will be low, sir. So overall, asymmetric IUGR having a better prognosis than the symmetrical IUGR, sir.
Okay. So yes, early stages of pregnancy, you call it a symmetrical IUGR, which is the inherent problem with the fetus. So what is IUGR is that the fetus is not gaining its growth potential. That is the fetus, how much weight it should have gained, it's not gaining that weight. That is what you call as IUGR. So symmetrical IUGR is the problem is with the fetus. Okay. But in asymmetrical IUGR, the fetus was growing initially well, but due to some, as you said, the uteroplacental insufficiency, inadequate supply of nutrition to the fetus later half of the pregnancy, they go in for the curve goes down. So that is what is asymmetrical IUGR is. Okay. So okay, proceed.
Now, what is the significance of asking fetal movements, pursuit of fetal movements pertaining to this case? You have a CNS case with the developmental delay since birth. What is the significance? If you have increased fetal movements, can it be some significance, or decreased fetal movements, can it be some significance?
Decreased fetal movements may be due to a neurological problem in the child, sir.
Yeah, if you have decreased fetal movements, so it implies there may be some hypotonia, which is very less. Okay. So at times it may have in utero fetal seizures, which may be perceived as increased fetal movements by the mother. What drugs you ask for other than IFA, iron and folic acid?
If the mother is under anti-epileptic therapy, we have to rule out the drugs, sir.
Phenytoin and valproate, they are more prone to cause neuronal damage in the fetus. Okay, good. Yeah, what about your third trimester?
Third trimester, as you said, as per your history, there's it's uneven. Okay. Okay. So the labor details, the mother had true labor pain and spontaneous rupture of membranes. Okay.
No foul smelling liquor, no maternal fever. How will you define maternal fever?
Hyperpyrexia, sir.
No, hyperpyrexia is entirely different. Definition is entirely different. What is maternal fever?
There will be maternal tachycardia.
Okay.
Increase in body temperature of the mother.
Any temperature
Sir?
with associated clinical features like here foul smelling liquor or abdominal tenderness, or without any clinical features, if the temperature goes beyond 39, it is very significant. Okay, during the labor or just prior to the labor. Right? Got it?
Okay, sir.
Okay.
Okay,
now,
sir.
why you ask this? Why you ask this? All these ones? Your foul smelling.
To rule out choreamnitis, which may be the cause for the preterm labor.
Okay, good,
Okay,
good. Next.
So here, the baby had so many problems immediately after birth, and so it was a preterm delivery. Okay, so the baby right from the birth had respiratory distress. So what are the causes? Yes, what could be the cause for this respiratory distress? Since the baby is born preterm, there will be decreased surfactant in the body, in the fetus, leading to hyaline membrane disease or respiratory distress syndrome, sir. It's the most common cause of respiratory distress in preterm infants. In preterm infants. Any other cause for respiratory distress? At birth, since birth, apart from your respiratory distress syndrome? So if it is a term neonate, there may be a transient tachypnea of newborn. Okay. Who's born through cesarean section. And okay. In IUGR, babies are more prone to get meconium aspiration syndrome, sir. Okay. During delivery, there may be trauma to the chest leading to pneumothorax. That may lead to respiratory distress.
You read a lot. Right.
You tell this in OG exam.
They will kick you out. Right.
Apart from this, when these babies are subjected to oxygen, high level of oxygen, they may go to bronchopulmonary dysplasia. Oh, that is later. That's not the cause at birth. Okay.
See, respiratory distress are on day 1 of life.
Your child is having respiratory distress on day 1.
Okay, what are the possibilities?
Congenital heart disease.
Okay.
Congenital heart disease is very rare, but okay. Because they present a bit late in the congenital heart disease, usually, not immediately after birth. So, in case of infection, can have congenital pneumonias. Okay, they can have pneumonias even at birth. Or any anomalies? Any anomaly you can think of? Anything?
Surgical conditions.
Common. Hernias, any hernia? Congenital diaphragmatic hernia, sir, CDH. Okay. So congenital diaphragmatic hernia. At least a few common things you should know for causes for respiratory distress at birth. Okay. Okay. So the baby. So what are the complications a preterm child can go in for? This child had a weak cry at birth, had respiratory distress. and even you presented it had neonatal seizures. Okay, so what are the complications a preterm child can go for that can lead on to a neurological deficit later or a cerebral palsy later?
Sir, intraventricular hemorrhage, sir. These preterm child are more prone to get intraventricular hemorrhage, sir.
Intraventricular hemorrhage, very good, very good.
And the metabolic abnormalities like hypoglycemia, hypocalcemia,
Hypocalcemia.
hypothermia.
Mhm.
And they also go for apnea of prematurity, sir. Due to immaturity of the respiratory center, they go for apnea of
Prematurity. Very good, very good.
One important thing.
Necrotizing enterocolitis.
Right.
Yeah, okay, accepted. But even before that, they can have necrotizing enterocolitis. So hypoglycemia, hypothermia, and it's a triad.
Hypocalcemia.
No, hypocalcemia doesn't come in the triad. They can go for hypothermia, hypoglycemia. One more thing. Sepsis. Okay. So preterm, they are more prone for sepsis. Okay. Even sepsis is one of the important sepsis and meningitis. Even if you treat them properly, treat them with treat them adequately, later on they can have neurological deficit. Okay, because of what is the pathology there usually in very preterm babies? The brain pathology that leads to CP in preterm babies usually.
Perinatal asphyxia, sir.
No, it's
No,
not.
no.
You are telling the physiology.
I am asking
Which
the pathology.
area of the brain is involved if there is some hypoxia or neuronal damage in a premature born? What you call as watershed areas.
Periventricular leukomalacia.
Very good,
Yeah,
very good, very good,
good,
very
good.
good. Periventricular leukomalacia, because that is the watershed region. So any insult can damage this, can affect blood supply to this area and can lead on to what is called as periventricular leukomalacia. Then, as you said, preterm babies by itself, they cannot withstand the stress of labor. Okay, so by itself, they can go for birth asphyxia. Prematurity itself can be a risk factor for birth asphyxia. Okay. Okay.
Yeah. Next. So this child was admitted in NICU, had seizures, almost stayed there for 30 days and was discharged with anti-epileptic drugs, right? So can you bring out the salient points from your antenatal to birth history, which are risk factors for developing this developmental delay in this child? You had many positive points, right?
Yes, sir.
That's the idea of asking the entire thing.
So we discussed everything in detail now. So we are coming to the crux. What we are taking out of this discussion. In this child, you point out from 1, 2, 3, 4. So these are the causes or risk factor which should have been the main cause for developing a developmental delay in this child.
That he will tell in the summary. You want to tell that in your summary or?
Sir, summary, sir.
Okay.
You will tell that in your
you
summary.
continue.
Continue. Okay. So day of onset of seizures, the mother is not sure. Okay.
Yes, sir.
So okay. Then in the postnatal also, the baby had problems like poor sucking. Okay.
Why are you more concerned about the day of onset of seizures? Is there any significance? For each and every question you ask, there should be some significance, right? You get a valid point out of it. Day 1 seizures, what is the cause? The newborn? Usual. I'm asking the commonest things, not the uncommon one like what you said in a difficult delivery and all. Okay.
Electrolyte abnormalities, sir. Electrolyte abnormalities.
Day one is asphyxia. Okay. From 24 hours to 72 hours, your electrolyte abnormalities like your hypoglycemia, that's your metabolic causes. Your hypoglycemia, hypoglycemia. Beyond that, your infections are most common. So that is the reason you ask the onset of seizures. Okay. If at all, if the mother would have given a history, sir, this child has developed seizures on day 1 itself, you are almost sure. So the child had an hypoxic insult during the delivery or something. that would have been the reason for all the problems here. Okay, got it? Right. Move.
Okay, so development history, the gross motor, the child has developed only up to 5 or 6 months. Sitting with support comes by 6 months. Okay, so 5 to 6 months is the developmental age for the gross motor. Okay, next. Fine motor, practically the child has not attained anything. That's what you are telling. Okay. Social and adaptive. Social. Okay. So overall, there is a developmental delay across the domains. Okay, this gross developmental delay across the domains. Okay. Okay. So you said you are telling the child has attained by 5 to 6 years and bisyllables. What is bisyllables? What is unisyllables? What is bisyllables?
Sir, ba, pa, and the single words.
Yeah. Okay. Good. Okay. So just unisyllable. Ma, da. That is what you call as unisyllable. What is bisyllable? Is mama, papa. That is what you call as bisyllable. Okay. In the bracket you have written 8 to 10 words with meaning. So bisyllable is not meaningful words. Bisyllable doesn't mean words with meaning. It's just sound. Bisyllable sound. Okay. So meaningful words 8 to 10 bisyllable usually is attained by what age? By 9 months. Okay. By 9 months child attains bisyllables. But to speak 8 to 10 words with meaning, what should be the age? Age should be at least 1.5 years. By 1 year, 2 or 3 words with meaning. By 8 to 10, by 1.5 years, the child will start speaking 8 to 10 words with meaning. By 2 years, simple sentences, 2 or 3 word sentences, the child will be able to make. Okay. So it's not the bisyllables, and bisyllables are not meaningful words. Okay. Bisyllable is attained by 9 months, and meaningful words is attained by 1.5 years. They are not the same. Okay. And your developmental age here should be 1.5 years. That's what one small correction you can make. 1.5 years instead of 1 year. That's what I think. Okay. So language. So according to you, the language milestone is somewhat better. You can say compared to the motor and other things, but almost practically all the milestones are affected very adversely. You can proceed. So vision, the child is able to fix and follow objects even with this. Okay, fine. Okay, the present illnesses, the child has presented with seizures which lasted for 1 hour. Okay, that's all. Okay.
Continue.
So altered behavior, sleep disturbance. So what sleep disturbance you expect? Why these children they have sleep disturbance?
Due to the insult to the brain, sir.
Insult to the brain, they can have seizures, electrical activity may be there. They'll have what is called as the sleep apnea. Okay, it's obstructive sleep apnea. So they will have sleep disturbance and altered behavior. What altered behavior was there?
Sir, not obeying the commands and stubbornness.
Stubbornness. Okay. But this child, I don't think you will be able to comprehend what you are telling. Okay, because the child is grossly affected. The milestones are grossly affected. I don't think the child will be able to comprehend what we say. Okay. There is no history of deviation of eyeballs. There's no deviation of eyeballs. There's no squint. You mean, according to the history?
Yes, sir.
History of abnormal involuntary movement of eyeball. What could that be? Abnormal involuntary movement of eyeball. What could that be?
Nystagmus, maybe nystagmus, sir.
Nystagmus. Okay. Able to respond. Okay. Next. History of difficulty in swallowing. Okay. So why these children they have difficulty of swallowing?
Cranial nerve palsy, sir, due to pseudobulbar palsy.
Very good. Cranial nerve palsies can be there. Okay. So what is you said pseudobulbar palsy? What is pseudobulbar palsy?
The fibers from the cortex to the cranial nuclei may be damaged, sir.
Okay. So there will be, that leads to
Incoordination between the muscles and the.
Okay, very good. Oromotor muscle tone is altered. Your tongue may be spastic. The palatopharyngeal coordination. So all your muscles of deglutition, everything, as you have stiffness everywhere. Okay. So what type of lesion it is? Human or LMN?
Human, sir.
Human. So it's a human type of cranial palsy of the lower cranial nerves. Okay. It's not the actually the bulb or medulla which is affected. It's because of the upper motor, the cerebral cortex, atrophy of the cerebral cortex. The fibers, the corticobulbar fibers, they don't convey the, they don't transmit the message properly. So the lower cranial nerves are affected, and that leads to tongue, all your tongue spasticity or tongue thrusting, your oromotor incoordination, then the increased oromotor tone. So they have difficulty in swallowing. Okay. So next is so there is stiffness of both upper and lower limbs noticed since 6 months. History of difficulty. So all these indicate what? History of difficulty in changing diapers, history of scissoring of lower limbs.
It indicates spasticity, sir. They increased tone of the
increased tone of the muscles, which we call as spasticity. Okay, proceed.
Now, what is the difference between spasticity and contraction?
Sir, long-standing spasticity will lead to contraction, sir, due to the unopposed action of the antagonist muscle, sir.
Okay, so spasticity, either of the one group of muscle will be affected, right?
Pro-gravity or anti-gravity muscle,
sir. Antagonist muscle. So contracture is pertaining to the joint. Okay, it changes the posture of the limb. Okay, so spasticity is pertaining to a muscle group. Okay, so what you are trying to bring out of this difficulty in changing the diapers, history of scissoring in lower limb. So what you say? So which group of muscles are affected?
So both upper limbs and lower limbs, sir.
I do agree. Okay. So you say the child is, mother is having difficulty in changing and wearing diapers. Okay. There is scissoring. So it's like this. Okay. So like a scissors. So which group is affected? Flexors or extensors?
Anti-gravity muscles, sir. Flexors of the lower limbs, sir.
Yeah, your flexors of hip, knee, your calf muscles. So those things are affected and spasticity. So because of that, it has has come to a shape of a scissoring, right? So that's why they are having difficulty in wearing diapers, holding the child in hip and etc. So, okay, fine. Next.
What you are describing here is the posture.
Difficulty in turning inward, difficulty in getting up. So his trunk is also affected. Okay, fine. So no cerebral involvement, right? Okay. Next.
So next, so gait and bladder and bowel, okay, normal. They are not affected. Sorry, they are. No control is achieved. Then complications.
Except for feeding difficulty and poor weight gain, no other specific complications.
So this
by
this
history.
By history,
Okay.
there is okay. So they have started on physiotherapy, though. So you mean to say that there is no contraction? Why history of fever? Is fever a complication of a child with the neurological deficit or CP?
Since the child is malnourished, they are more prone to get infected, sir.
Okay, that can be the
No,
complication.
that is not a complication of the inherent problem.
Inherent
See,
problem.
what you ask is the problem, the neurological problem and its complications, your history. Okay, you and me also will get fever. Any problem will may cause fever. Okay, that is not the specific complications you have to ask.
Okay. No vomiting, headache, altered sensorium. What all that for?
Could see as infection, sir.
So you think of CNS infection here?
No, sir,
so this child you don't think of CNS because the problem is present there from birth. Okay, and child is already had convulsions, and now again also child is having convulsion. Obviously there's no history of fever. Okay, so you don't have to think of CNS infection in this child. Okay, proceed. So they are prone for recurrent respiratory infection, and you could have asked for cough, cold, breathlessness with fever means you thought of recurrent respiratory infection and fever. In that way you can explain, but not of not like CNS infection. Okay. Next, proceed. So they have started on physiotherapy. Okay.
Now, why these child are more prone for respiratory infections?
Due to aspiration, sir.
Okay,
Okay.
next. One is aspiration, right?
Immaturity of the respiratory system, sir. Because they are born.
System is immature. Your CNS alone is a problem, right? So one is your aspiration. Second is you, as you said, these child are grossly malnourished, right? So their immunity will be very poor. Their oral hygiene and dentition will be very poor. So they are more prone to get those infections into the parenchyma, and thus they are more prone for recurrent respiratory infections, right? Family history, no history of developmental delay, neurological illness, seizures, okay, history of stillbirth. Okay, you should also ask about any behavioral problems in any other sibling, if at all. If that is this child is an only sibling, or you have to look for any autism or something. Okay, if you are thinking about family history in a neurological case. Okay, with the other child, any cognitive disturbances or behavioral problems, you should ask. Okay. Next.
Okay.
Socioeconomic status. Okay. Okay, nutritional history.
So there will be a protein gap. We expect a protein and calorie gap because we expect feeding problems. The child with a feeding problem, the mother won't be able to feed the prey properly, caretaker. So we expect some protein and calorie gap. Okay, so that is there in this case. Okay. Okay, so can you summarize now?
11-year-old male child Raghu of second order birth, born to an open to non-consanguinity, belong to upper lower class, according to modified Kupusamy classification, with complaints of delayed milestones noticed since birth. Convulsions in the form of tonic posturing of both upper limb and lower limb with uprolling of eyeball and frothing lasted for 1 hour. With antenatal history of second trimester scan showing low fetal weight, and significant birth history in the form of moderate preterm low birth weight, weak cry at birth, respiratory distress, feeding difficulty, and neonatal convulsion, admitted in NICU for 1 month. His gross motor milestone developmental quotient was 4%. Fine motor milestone developmental quotient was 3%. His social and adaptive milestone was developmental quotient was 3%, and his language milestone developmental quotient was 9%. With intact vision and hearing, bowel and bladder control not yet achieved. History of stiffness of upper limb and lower limb noticed since 6 months. Child is not able to lift arm above head and is not able to eat with spoon. He is not able to get up from supine position and unable to stand and walk. He has difficulty in swallowing solid food more than liquid food and not gaining weight adequately. He was on physiotherapy for the past 4 months. He was immunized till date. History of stillbirth in the family. He has calorie deficit of 900 kilocalories and protein deficit of 13 grams. Probably a case of global developmental delay, spastic cerebral palsy.
Summary should be a summary.
Yes, everything, right.
So you don't have to describe everything again in summary. It should be brief as possible, just the gist of what you have told. Okay. So you don't have to describe again about just say the child had convulsions. You don't have to describe about the convulsions again, and you can say the developmental delay in, affecting all 4 domains. You don't have to again describe about the development quotient and everything in the in detail here also. Okay. So obviously your CNS is affected here from whatever you have told. CNS is affected here. Which part of CNS you think is affected? Which part of the nervous system, central nervous system, you think is affected here? Is it the peripheral nerves? Is it the peripheral nerves affected?
Central nervous system.
Okay. Which part of central nervous system is affected? Spinal cord? Can it be a spinal cord problem?
Brain, sir.
Brain. Okay, accepted. Why do you say brain? Okay, brain. Which part? So, what are the which part of the brain you think is affected?
Since the baby is born of preterm, the periventricular area may be affected, sir.
Periventricular area. So only the periventricular area is affected means which part? Why do you say so? Why periventricular alone you think of? If you want to localize, it could be a cortical lesion or a subcortical lesion, or at the level of internal capsule, or a brainstem lesion in the brain. Okay, or lower down it can be a spinal cord. Obviously, you said the lesion is not due to spinal cord. Okay,
Cortical
why?
lesion,
Why now? Why do you say cortical lesion?
sir. Because the baby is having spastic type of hypertonia, sir.
Spastic type of hypertonia you can have in periventricular leukomalacia, as you said, subcortical lesion also. So there is a diffuse involvement, one thing. Okay.
You have mentioned very clearly history of stiffness of upper limb and lower limb. Notice since 6 months, both your upper limb and lower limb are equally involved as per your history, right?
Okay. So there is diffuse involvement of all the parts. Okay. So there is diffuse, and moreover, the child is having mental retardation. Is it not? Okay.
Sir.
Child is having convulsions. Okay. Child is having altered sensorium, convulsions, mental retardation. Okay. So behavioral disturbance. Okay. All these point towards, yeah, which part of the brain should be affected?
Cortex, sir.
Cortex. So all these are supporting your cortex. Okay. If it is going to be a subcortical lesion, your behavior problem or convulsions may not be there. Okay. And the lesions and it will be more dense subcortical if it comes down to internal capsule. So internal capsule, either one side internal capsule may get affected. It's very, very unlikely that either the either side internal capsule gets affected and leads to quadriplegia. Even there, you won't have the higher functions or mental retardation or the seizures. The child won't have seizures or any other higher functions affected in internal capsule. Okay, if you come down to brainstem, what will happen?
Difficulty in respiration.
Okay, difficulty in respiration. The other parts may be affected, or you'll have the cranial nerves affected.
Cranial
Okay.
palsy.
What type of cranial nerves? What type of palsy you will have in brainstem lesion?
Element type of cranial palsy.
Element type of cranial palsy. That's why I asked you. Okay, well, why this child is having feeding problem? You said it could be a pseudobulbar palsy, which could be due to a upper motor neuron type of cranial nerve palsy of the lower cranial nerves. That's what you said. Okay, here it's more of a upper motor neuron type of a cranial palsy. But when it comes down to the brainstem lesion, it will be a lower motor neuron type of cranial palsy. Okay, so and spinal cord. Spinal cord transection. Okay, without any cranial nerve involvement. Okay, that's where the, so here the most probably the lesion should be at the level of the cortex. Okay, so here the lesion should be at the level of the cortex, not the subcortical or the internal capsule or the brainstem or the spinal cord. It's more towards the cortical lesion. Okay, and you understand? Okay, okay. So now coming to the as you said, coming to the etiology. So what could be the etiology, or what could be the pathology?
Sir,
Can it be an infection?
No, sir.
Why?
Because there is no history of neonatal fever, sir. Neonatal sepsis, sir.
And the problem is the child is having problems since birth. Okay, so it's less likely. Okay, so can you? So since the child is having problems from birth, can it be a degenerative disorder? Can it be a degeneration?
Degeneration, neurodegeneration. It's a progressive disease, sir. Neurodegeneration, a progressive disease, and the regression of the milestone, sir.
Very good. Okay, so neurodegenerative disorder is a progressive disease. There will be regression of milestones. But here, what you have?
It is a static.
Here in cerebral palsy, it's a static encephalopathy. It's a non-progressively. The lesion is non-progressive. Okay, so what happens in neurodegenerative disorder is the child develops normally for some time. Then there can be some developmental delay, or there can be a static period. After that, they'll start losing the already acquired milestones. That's what happens in the neurodegenerative. That depends on the rate of progression of the disease and the rate at which the child develops. So depending on the rate, okay, some of the milestones may be delayed, and after that it may be static, and after that it may start losing the milestones. But here in your child, what happened is the milestones were attained very late, but it has not lost any of the attained milestones. Is it not?
Yes, sir.
So you have, the child has not lost any of the milestones. By 2 years, social smile, I think you said by 2 years it started recognizing the mother, and by 4 years it was able to sit with support. That's what you said. But it has not lost those milestones. So this is more of what could be this due to? This could be more of a congenital problem, which could be you have got every reason to think of a congenital. Congenital problem is problems present from birth, like preterm or like like a perinatal insult or any other congenital malformation which could have led to this scenario now. Okay, so this is more. This cannot be a degenerative disorder, or this cannot be any demyelination or a vascular problem, because those are all very acute. Okay, and infection very less likely. So this could be due to this perinatal insult, which has led to the condition now. Okay, you understand?
Yes, sir.
Okay.
Okay. Now, why do you say this is a global developmental delay?
Global development, because there is a development delay in two and more domains, sir.
So significant developmental delay involving more than 2 domains, you mean to say. Okay. So justify, as Sir said, you give me points why it is a cerebral palsy.
Sir, since the baby is born of preterm, sir.
No, you leave that etiology. Okay. Now tell me, this is cerebral palsy, you say. So you are given 3 words in your probable case. It is global developmental delay. You are given answer. Spasticity, you have already answered. Okay. Now you say it is cerebral palsy. From the history alone. Okay. Why you say this is a cerebral palsy?
So there is no regression of the attained milestone, sir.
So it is a non-progressive, accepted. As Sir explained, it is a non-progressive. So the acquired skills are not lost. Okay, right. So insult is when the insult happened.
Since birth, sir.
The insult should happen in a developing brain. Okay, so not beyond 2 or 3 years. Okay, some fall or something, and everything is going on quadriplegia. It's not a CP. Okay, insult should happen to a developing brain, and the insult should be permanent. Okay, so right. Can you give me some better terminology other than global developmental delay? Till what years you will say it's global developmental delay?
No idea, sir.
No idea. Till 6 years you can say or use the term, it is global developmental delay. Beyond that, the better terminology would be intellectual disability. Okay. So for case presentation, okay, because you are always talking as developmental delay, it's not matters, but you should know beyond 6 years, the terminology, better terminology would be a intellectual disability. Okay, right. Okay, move.
General examination. The child is conscious, not oriented. Speech, memory, intelligence could not be tested. Sleep normal. Emotions, excessive cry. Pallor present. No icterus, cyanosis, clubbing, lymphadenopathy, and pedal edema.
Right.
Vitals, heart rate is 96 beats per minute, respiratory rate is 22 per minute, temperature afebrile, BP 106/80 millimeter mercury, anthropometry, weight 14 kgs, which is 42% of the expected weight, height 110 centimeters, which is 76% expected weight, head circumference is 45 centimeter, which is less than third centile. Head to foot examination. Head microcephaly, anterior fontanelle closed, shape of skull normal, no alopecia. Face, there is no dysmorphic faces. Eyes, there is no drooping of eyelids, convergent squint present, nystagmus present, and no cataract, no signs of vitamin A deficiency. Ears, there is no low set ears and no deformity. Nose normal. Mouth, no drooling of saliva, poor oral hygiene, dental caries present, no glossitis, chelatis, no tongue thrusting. Chest, there is no deformity, no rachitic rosary. Abdomen, hernial orifices are free. No bed sores, no neurocutaneous markers, spine normal, no involuntary movements. So shall I proceed, sir?
So we have completed general examination and head to foot examination, right? So I just want to point out two things. In general examination, in a CNS case, that too in a CP case, you have to mention about the appearance or the posture more than your conscious oriented other things. When you see the child first, how the child looks, okay? You have flexure, contractures, and other those things, okay? Those things you have to say. Second thing, you just move one slide. Yeah, this mouth, okay, this oral hygiene, dentition, this is more important, right? So those two things are very important in the case of general examination, right? Okay, next.
Cranial nerve examination. First cranial nerve could not be tested. Second cranial nerve, gross vision normal, visual acuity, color vision cannot be elicited. Menace reflex present, pupillary reflex present. Third and fourth cranial nerve, convergence squint present, accommodation reflex cannot be elicited. Fifth cranial nerve, facial sensations intact, no deviation of jaw, corneal reflex present, conjunctival reflex present, jaw jerk present. Seventh cranial nerve, there is no deviation of angle of mouth, taste sensation cannot be elicited, corneal and conjunctival reflex present. Eighth cranial nerve turns head towards sound stimuli, Rinne and Vivatis cannot be elicited. Ninth and 10th cranial nerves, gag reflex exaggerated, no deviation of uvula and no nasal twang. 11th cranial nerve, able to turn head side to side. 12th cranial nerve, no wasting of tongue, no abnormal movements of tongue, able to protrude tongue out, no deviation of tongue.
Okay, so you said there is a convergent squint in this child, but in the history you said there is no deviation of the eyes. Maybe the mother didn't notice.
Yes, sir.
Okay. So how do you classify this squint?
Paralytic squint and non-paralytic squint, sir.
Very good. Okay. So what do you think this squint is?
Sir, it may be due to a refractive error, sir, which cause.
This is a paralytic or concomitant? Non-paralytic. What is this squint?
Sir, it may be non-paralytic squint, sir.
Okay. So what is the difference between paralytic squint and non-paralytic squint? Where do you get paralytic squint?
In extraocular nerve, the nerve supplying the extraocular muscles may get paralyzed.
Very good. So when there's a nerve palsy, okay, nerve palsy due to any reason, maybe some CNS problem like TB meningitis or wherever, you get nerve palsies. So in that case, you will get paralytic squint. Okay. So what is the difference between paralytic squint and non-paralytic squint? How will you differentiate? Based on the movement of eyeballs. So what happens in paralytic squint is non-paralytic squint. What happens is only the angle of separation, the angle of deviation or the separation between the eyes, that will be constant in all directions. Okay, in whichever direction the child moves the eye, so the deviation will be constant. The angle of deviation will be constant. But in paralytic squint, what happens is only in the direction towards which the nerve palsy is there, only in that direction you will have that angle of deviation. Okay, when the eye is moved to the opposite side, you may not have that that angle. So the separation of the eyes is not constant. Okay, so the movement of eye is affected only towards the side where there is nerve palsy. Okay, so that is what is a paralytic squint is. Okay, but in which condition you will have diplopia, paralytic squint or non-paralytic squint? So in paralytic squint, you will have diplopia. Okay, because non-paralytic squint, the child would have adapted. The image from one eye would have been suppressed. Okay, so the other eye alone will be receiving the impulses. Okay, the brain will suppress one eye. Okay, so that is what happens in a non-paralytic squint. So in conditions like cerebral palsy, what you get is a concomitant squint or a non-paralytic squint. Okay, in nerve palsies you will get paralytic squint. Okay, so proceed. Next, you said gag reflex is exaggerated. Why you think gag reflex is exaggerated? I mean, you just now you said the answer.
Now, when you are discussing about the history and symptomatology, you answered right.
Sir. Because of pseudobulbar palsy.
Very good, very good. Pseudobulbar palsy, you said what type of palsy it is?
Human type of palsy. The reflexes will
Human
be
type of
exaggerated, sir.
yeah, yeah. So in pseudobulbar palsy, it's a human type of palsy. So your reflexes are will be
Exaggerated.
exaggerated. That's why your gag reflex is exaggerated. Very good. Okay, okay. Proceed.
Continue,
Proceed.
Motor system, bulk, upper limb, arm right side 11 centimeters, left side 11 centimeters, forearm 13 centimeters, on right side, left side 13 centimeters, lower limb, thigh right 25 centimeters and left 25 centimeters, leg right side 18 centimeters and left side is 18 centimeters. So tone is increased in all the 4 limbs, sir. And
Okay.
power is 2/5 in all 4 limbs. Reflexes are brisk and bilateral plantar extents are plantar, sir.
Okay.
No ankle clonus and superficial reflexes are present, sir.
Okay.
A sensory system, the child is able to feel pain, temperature, vibration, and touch. Cortical sensations cannot be tested, and tactile localization and 2-point discrimination cannot be tested. Rhomboxane cannot be tested, sir.
We're able to test vibration sense in this child. Okay. I don't think that would have been possible. Okay, proceed.
Cerebellum, no titubation and no intentional tremor. Upper limb, finger nose test, finger test, and this datacokinesia, heel shin test, draw a circle in there cannot be tested. And nystagmus, pendula knee jerk, and rebound phenomenon is also not tested, sir. 8 could not be tested. Spine normal, no signs of meningeal irritation, and no involuntary movements, no signs of neck stiffness. Other systems, CVS S1 S2 here, no murmur. Respiratory system, normal vesicular breath sounds here, no added sounds, bilateral air entry equal. Abdomen, on soft palpation on soft bowel sounds here, no organomegaly. Diagnosis, a case of global developmental delay.
Now you summarize your positive findings.
Sir, in motor system, there will be increased tone in all the 4 limbs, sir.
Okay.
And there will be reduction, and there will be reduction in the power of the all the 4 limbs. There will be reduced to power, sir. And the reflexes are brisk and bilateral extensor plantar is present, suggestive of human lesion, sir.
Okay.
Sensory system is intact, sir. There will be pain, temperature, vibration, and touch. The child is able to feel, sir. And there is no signs of abnormalities of cerebellum, sir. Cerebellum signs, there is no signs indicative of cerebral dysfunction, sir. And the spine is normal, and there is no involuntary movements, and there is no signs of meningeal irritations and no signs of neck stiffness, sir. And other systems are normal, sir.
Cranial nerve?
Cranial nerves, convergent squint is present, sir. Gag reflex exaggerated, and gross vision is normal, and hearing the child is able to turn towards sound stimuli, sir.
Okay.
There is no other cranial nerves.
Did you look for primitive reflexes?
Yes, sir. Should be tested, sir. Should be looked for, sir.
Did you see?
No, sir.
You didn't. Okay. So you should have looked for. Okay, what are the primitive reflexes you look for? At least you just tell.
Sir, there are certain reflexes which are present before, during birth and after birth, sir. For example, asymmetric tonic neck reflex.
Okay.
And Morose reflex, rooting reflex, palmar grasp, and symmetric tonic neck reflex, and parachute reflex, which is persists throughout the life.
Okay, very good. So at least you should know that you should check the primitive reflexes. Asymmetric tonic neck ATNR is very important. At least bigger child, you could not have done that 180-degree flip and all, but at least ATNR you could have checked asymmetric tonic neck reflex. Okay.
Shall I?
Now you summarized. Okay. Now tell me.
Sir, shall I continue, sir?
Yeah. You continue.
Diagnosis: it's a case of a global developmental delay with spastic quadriplegia, cerebral palsy with grade 4 gross motor function classification system with seizures, malnutrition, anemia, feeding difficulty, and behavioral problems. Most probably the etiology being a perinatal insult. Sir.
No, you hold on here. Yeah. Behavioral problems. Okay, you say it is spastic quadriplegia, right?
Yes, sir.
Okay. So what? Any other types you know?
Yes, sir. Spastic quadriplegia, spastic diplegia, spastic hemiplegia, and spastic monoplegia and spastic doubleplegia are also seen, sir.
How well you can classify
Topographical classification and physiological classification, sir.
Okay. Very good.
Topographical classification: spastic type, ataxic type, dyskinetic type, and mixed type, sir.
What is it?
Dyskinetic and mixed, right?
Mixed.
What
And
is
physiological.
Physiological is?
Physiological is involving the topography means the.
Now what you said is, no, you said 4, right? So what is that classification?
Physiological, sir. Sir. Topographical is based upon which limbs are affected, sir.
Where are your friends, Jeffrey and Manigandan? Are they here?
Sir, Sujay is here, I think, sir.
Sujay is okay. Anybody can answer. It's not that only Prithviraj should answer. Okay. Okay, so topographic classification, you said topographic classification, you said physiological classification, okay. Then functional classification. Functional classification is nothing but just the grade you said.
Given
okay.
grade 4, right?
Given grade 4. That is one classification. Okay. Grade 1 is no limitation of activity. Grade 2 is mild limitation of activity. Grade 3 is moderate limitation of activity. Grade 4 is no practical, no useful movement at all. Okay, that's what this functional classification is. Then based on the etiological classification. That's all that what you have given your diagnosis is nothing but based on your classification. Okay. The fourth one is the etiological classification. Etiological classification can be a prenatal or a natal or a postnatal. Depending on the time of insult, you call it as a prenatal. Okay, prenatal could be, the causes for prenatal insult could be
congenital malformations of the nervous system.
Very good.
Intrauterine infections.
Okay.
There will be
teratogens.
Maternal obstetric complications, maternal aplasia.
Okay.
Hemiplegic CP and teratogens. And perinatal causes toxins.
Okay,
perinatal causes
and
birth
intrauterine also there can be hypoxia. Okay. Okay. Hypoxia can be there also. Okay.
And perinatal causes birth asphyxia, birth trauma, producing intracerebral hemorrhage, CNS infection.
CNS infection cannot be natal. Okay, it can be postnatal. Okay. Postnatal you can have infections. Okay.
And hyperbilirubinemia and
toxins. Okay. Hyperbilirubinemia.
And postnatal causes any hypoxia, either two maybe toxins, trauma.
Okay.
And CNS infection, sir.
So now you know all the types of classification. One is topographic, physiologic, then your functional and etiological classification. This is how you classify cerebral palsy. Okay. 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 So can you tell the definition of cerebral palsy?
It is a non-progressive permanent disorder of tone, movement, and posture due to insult to the developing brain. Motor domain is more predominantly involved, sir. Other domains may be normal or may not be normal, sir.
Okay.
It is a type of static encephalopathy. Okay.
So it's a non-progressive neuromotor disorder of cerebral origin. Okay. Cerebral origin that results due to insult. That word is important. That results due to insult to the developing brain. Okay. So what is the period of active brain growth?
Up to 2 years of age, sir.
Up to 2 years of age. Very good. So up to 2 years of age, if there is any insult, maybe in the neonatal period also the child may have some sepsis and meningitis. Okay, then again technically you can call it as a case of cerebral palsy, because that has occurred during the period of active brain growth. Okay. 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 So how are you going to investigate this child? You want to investigate this child?
Yes, sir. We have to go for a thorough history and also a physical and neurological examination to assess the development properly.
Okay, very good.
And we can go for imaging studies, sir.
Imaging studies. You want to do imaging studies. What imaging you want to do?
Since the soft tissues of the brain is involved, we can go for MRI, sir. MRI brain, sir.
Okay, okay, okay. So MRI will be a better imaging modality. Okay. So why? What all you can get in MRI?
There will be early recognition of periventricular leukomalacia. We can recognize periventricular here.
Very good.
And periventricular hemorrhagic infarct.
Very good.
The brainstem and basal ganglia anomalies can also be seen through
so you
MRI.
can know the extent of the damage as well as the etiology from MRI. Okay, as you said, you can pick up periventricular leukomalacia earlier, or any congenital malformation. You said in the prenatal congenital malformation like lissencephaly and all. Okay, that may be picked up better by MRI than your CT. Okay. Okay. Any other investigations or you want to do?
Since electroencephalogram, sir, because the seizure is the child is having recurrent seizures, we can go for electroencephalography.
Okay, that again to know the extent of the involvement. Okay, proceed. Very good. Then
CT is not of much use, sir, here in this case.
Okay, accepted. Okay. Certain situations you can use, but okay, accepted. Okay.
In case of small abnormalities of the head size or suspecting congenital infections, we can go for a CT scan, sir.
Okay, okay, okay.
Not in this case. Generally, we can go for in case of suspecting congenital infections. In neonatal period, we can go for a neurosonogram, sir. Since in the anterior frontal is open, we can go for neurosonogram, sir.
Okay, okay. So the serial ultrasound, okay, not just one neurosonogram will be will be useful. You will have to go for you will have to do a serial neurosonogram. Okay, okay.
So these are the investigations we do, sir.
Any other investigation apart from for your evaluation purpose?
Sir, blood investigation, sir.
Okay.
Sir, if you are planning for surgery, sir, for to remove the contractions,
you have gone too far. Okay, I am not to that level. For you have gone to the level
to
of
find out craniosynostosis, sir. X-ray to find out craniosynostosis.
Okay, but the child is with you. You are going to plan management of this child. So before that, you want to evaluate or assess something. Anything you will assess before starting your evaluation? Before starting your therapy, I mean? Any assessment of
development, sir? Assessment of development.
Development. Okay. Anything else? So vision, hearing.
Those things you have to see, right?
Okay.
So other comorbidities you have to work out, right?
Because you say, even though you said the child is able to fix and follow objects, you also said there's a convergence squint. You said there could be a refractive error which could have led to this convergence squint. One. Okay. And you said, I remember you telling nystagmus.
Yeah.
Okay, you said nystagmus in this child. Okay, that again could be. So that means what could be the cause for nystagmus in this child? The child is having some visual defect. Okay, that means the child is having some visual defect. Maybe the child may be following the objects or following some bright objects, accepted. But still, we are not sure whether this child, the vision of this child is totally normal or not. Okay, so that's why the child is having nystagmus. It's not able to fix to a particular object. So in that case, okay, it may have nystagmus, and child is also having convergence squint. So you'll have to do a visual assessment for this child. Okay, and hearing evaluation also you'll have to do, because we don't know how good is the hearing is. Okay, so that is essential for your language development. Okay, only. Okay, so vision and hearing also you should assess. Okay. 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 So next, how will you manage this child?
This is a multidisciplinary approach, sir.
Very good. Very good. So multidisciplinary
Physiotherapy
approach.
consists of physiotherapy, pharmacotherapy, and surgical aspects, sir.
Okay.
Requiring a pediatrician and ENT surgeons, ophthalmic surgeons, operational therapist, and speech therapist, and psychiatrist, orthopedic surgeons. And for we can give some drugs, sir, for pharmacotherapy. For physio, first you can do for physiotherapy, sir.
Okay. So when will you start giving all these therapies? This child had is a preterm delivery, 1.5 kg at birth, had a stormy neonatal period. Okay. So when will you start, or how early you can identify, and when will you start physiotherapy for therapies for this child?
So after
this child is physiotherapy was started by 6 years.
yes,
Is it not? You said
Yes,
physiotherapy
4 years back,
was started at 6 years.
6 or 7 years.
Okay. So is that okay for you?
no, sir, no, sir.
Then when will you start? It should have been started very.
First year of life.
It should be started very early, even before that. Okay. Okay. As early as possible. Why early stimulation? What we say is early stimulation. Why early stimulation? Why should you start it early?
To prevent contracture, sir.
Prevent contracture. Okay. Our idea is not only to prevent contracture. The idea of giving physiotherapy is to make the child more functional, to improve the necessary.
Abolish abnormal movements.
Very good. To abolish abnormal movements, to improve normal movements, to normalize the tone. Okay. For suppressing the primitive reflexes. For that purpose only you do physiotherapy, not just to prevent contracture. Okay. So early stimulation means the results also will be better. Okay. So why the results are better? What is cerebral plasticity?
So it is accommodation of the brain, sir. We can modify the functional ability of the brain, sir, by doing the physiotherapy, sir.
Yes, very good, very good. So what we are trying to do is we are trying to do things, and some part of the brain, we don't know which part is going to take over. Some other part of the brain, not the conventional one, that part takes over this function. Okay, and the child may become functional. That is the idea. So this can happen only if the interventions or therapies are started early. Okay, so once the brain has attained certain stage, or once the brain has developed completely, then whatever effort you are going to put in may not give as much as the results as expected. Okay, so the intervention should have been started even just after the neonatal period, even the early months, early infancy. It should have been started, which perhaps this child has missed. Okay. So physiotherapy, you will do any other therapy?
Sir, pharmacotherapy, sir.
Pharmacotherapy, you give drugs for
Thwarting seizures, sir.
Very good, seizures. Okay, then
and drugs to reduce the tone, sir. The spasticity for drugs can be given for reducing the tone, sir, for spasticity. You can go for baclofen, diazepam, and tisonidine, sir. And other involuntary movements can also be aborted, sir, by giving levodopa and trihexyphenidyl. Other comorbidities can be treated, sir. If there is a malnutrition, we can go for nutritional supplements can be given, sir.
Very good. Okay.
And behavioral problem.
Treating your malnutrition, you have to treat or support your feeding problems, right?
Yes, sir.
So how are you going to do that? The primary problem in a CP to start with is a feeding issue than your development, right? So how are you going to address that?
Expressed breast milk feeding, sir. We can.
Okay. In general, you have to give it in a proper position. You can use your prokinetics, okay, to prevent vomiting, and okay. So your feeding issues has to be addressed. Okay. Your dental problems, your oral hygiene, those things should be addressed. So along with all your measures. Okay. So Sahar said you have to do all these stimulations. Okay. Your visual, hearing. Okay. So if I ask you one question, where will you send this child?
District Early Intervention Center, sir.
Good.
Very good.
Do we have in Madurai?
Yes, sir. We are having Madurai, sir, opposite to our OP, sir. We are having, sir.
Right. Yeah. Right. Okay.
They are giving cognitive therapy, speech therapy, occupational therapy, and behavioral therapy, sir. These are the 4 things we are there.
Okay. Very happy to hear that you know all these things.
Right. Yeah.
Okay.
So it is a recently brought specialized
new
department.
concept.
Is doing wonders actually. Okay. So the early stimulation and all your therapies are being brought under one roof for the betterment of this child. Okay. Okay. How would be the prognosis of this child?
The prognosis depends upon certain features, sir. The child will be the prognosis will be poor if there's a quadriplegic CP, sir. And if the child is still not able to sit with support by 4 years and standing with support by 7 years, based upon domain, sir.
Okay.
And there is persistent of neonatal reflexes still by 2 years, sir. These are the poor prognostic features, sir.
Very good. Okay. Based on the
in case of diplegic CP, the prognosis will be good, sir. In diplegic CP, the prognosis will be good, sir.
Okay.
And surgical aspects also we can go for, sir. Tendon release, osteotomy, arthrodesis, muscle transfer, neurectomy can be given.
Okay.
So all that we can do is the insult is already happened. Okay, we are trying our best to bring out the baby child more functional. Okay, so that's what. So if taking your child, it's almost 11 years. They have started their medical attention too late. So this should not be the case in all children. Okay, there should be, you should early suspect, you should diagnose early, and you have to intervene early. So for that reason only we people are here, right? Good. Can we prevent cerebral palsy?
Yes, sir. We can prevent cerebral palsy, sir, by giving maternal iron and by giving maternal folic acid periconceptionally, sir, before 1 month of gestation. And also the maternal illnesses should be treated promptly, sir.
Okay.
And
promoting maternal obstetric care. Okay.
Promoting institutional deliveries, sir. Promoting institutional deliveries.
Okay.
And the neonatal problems should be treated, sir, like hypoglycemia, jaundice. They should be addressed, sir.
Okay.
And your child, this baby is
prematurity.
Can any drug to the mother?
Prematurity.
Steroids can be given, sir, for prematurity.
What?
Antithetic steroids. Sir?
We are winding up. 2 minutes.
2 minutes, sir.
We are winding up, sir.
We are almost there.
Sir, we didn't get you.
Yeah, Sallai, intervene. Hello?
Sir?
Yes, sir.
Yes, sir.
The intervene parlama nane.
Sir, Dharalama.
Yes, sir.
Yes, sir. Yes, sir.
Yes, sir. Yes, sir. Sure, sir.
Yeah, good. Actually, sir said no that folic acid. I think the folic acid one of the things you can neural tube defect we can prevent. Okay. So what's the percentage of cerebral palsy produced after delivery? Otherwise, what's the percentage of CP?
2 to 3 infants per 1,000 live births, sir.
Okay. And my question is during delivery, birth asphyxia, no?
Less than 10%, sir.
Yeah. Only 10% only get due to birth asphyxia.
Yes, sir.
Remaining 90% the insult is happening in the intrauterine itself. Okay.
Yes,
so
sir.
Intrauterine itself it's happening, and as Dr. Karthik said, no, one thing is you can have folic acid and you can have you can prevent. That's one preventable things. So a lot of other causes also will be there. Okay. So many times in medical legally, many there's suing on many position because of birth asphyxia, babies having cerebral palsy. It's not true. Only 10% of the CPs from the birth asphyxia. 90% from the intrauterine itself. Okay, this is your understanding. Okay. And I think it's nicely you have to discuss everything. At a single man army, Prithviraj, I think what about other two? They are I think just like that watching anything. What about others? Other undergraduate they are watching, no? Two UG. Yeah. Okay. No problem. Good. Okay. Proceed, Dr. Ram.
Yes, sir. Yes, sir.
No problem. You can take 15 minutes.
Yes.
No problem.
Well, we are almost over, sir.
No, we are almost over, sir. We are just we thought of sticking on to time, sir.
Prithviraj.
Yes, sir.
Yeah. So we are talking about steroids. What are the complications in preterm that can be prevented by antenatal steroids?
Respiratory distress syndrome, sir.
Very good.
Necrotizing enterocolitis.
Good.
Intraventricular hemorrhage.
That's very important. In this
Excellent.
case, so preventing an intraventricular hemorrhage in a preterm child will prevent the development of CP. Okay, so the periventricular damage, everything will be mostly because of your intraventricular hemorrhage. Okay.
Neonatal jaundice cannot be prevented by giving antenatal steroids, sir.
Okay. Extra point. You are saying.
Excellent.
You read everything and you want to convey everything, right? Good.
Very good. Okay, so that was a very good effort and a very nice presentation from your side, and you have prepared well. Okay, congrats and keep it up, Prithviraj. Okay.
Because presenting an CNS case in a final year is very difficult. That too a CP, that too in an open virtual forum where all medical college students are seeing. Really kudos to you. A really nice presentation and nice preparation.
Very good. Keep it up.
Thank you.
Keep it up. Okay.
Thank you.
Thank you.
Yeah.
Sir,
I think it's
it's over, sir. Thank you.
Presentation. I think next it's CP's static encephalopathy, and treatment wise early referral to the occupation therapy. That's very important thing is occupation therapy is the mainstay, and other thing is multidisciplinary approach. Okay, and I think sometimes a child is having drooling of salivation. Nowadays we are using Botox also for the injection to the parotid also, and if they are taking the contraction also, they are using Botox prior to surgery. I think they are using Botox injection also. Okay, even if there are small muscles and the contracture area, you can use Botox, the botulinum toxin. Okay, that's the injection they are using. And I think many times the non-surgical approach also better. I think you can go for. And lot of times nowadays they are having specialized wheelchairs and a specialized computer, and a lot of things are coming up. Okay. And I think it's overall is a nice presentation. I think undergraduate, I think Prithviraj presenting like a postgraduate, I think.
Yes, sir. Yes, sir.
Yes, sir. I think man army, I think we handle everything. I think all the other two undergraduates is just observer, I think. Okay. Okay, anyway, good presentation. Okay, on behalf of IAP TNC, I thank Dr. Ram Subramaniam and then Brigadier Karthik also. I think he has done excellent work on both combo. I thank Madurai Medical College and students, and I thank our Palashankar sir who is keen to present this case in our IAP TNC forum. I thank one and all for this wonderful presentation. And Dr. Ramasubramaniam, do you want to tell anything? Yeah.
Okay. Thank you, sir. Thank you. Nothing. Okay, sir.
Thank you.
Thank you, sir.
Thank you, sir.
Thank you, sir.